should you even dump blood?
There's no reason to dump blood. Zero.
Thank you. I created Species Nutrition with one mission in mind: to provide bodybuilders and serious athletes with no-nonsense supplements that work. I put my name and reputation on every bottle of Species Nutrition products. If you want to be your absolute best, join the evolution. Welcome back to another exciting episode of Guru Talk. I'm Dave Palumbo. Today I'm joined as always, but not as always, by my good friend Dom Mutascio, who you guys know as one of the top coaches in bodybuilding, and also special guest Dr. John Pierce, who owns the Las Vegas Ageless Forever Rejuvenation Clinic. Guys, welcome to the show.
Thanks, Dave. Thanks for having us.
And, Dom contacted me, as he always does every once in a while, because we're friends. And he said, hey, Dave, I got an idea for a really good show. I got a really good guest. He's a doctor. He's prescribing, testosterone. And, Dom, you and I kind of have like a similar frustration with a lot of the information that's being put out on the internet, especially on social media and TikTok and Instagram. Everyone thinks they're an expert and they know everything about everything because they've been, they've been watching TikTok videos for a whole year. And so they're experts in testosterone, they're experts in endocrinology, they're experts in coaching. And I like to get real experts on the show because people don't know where to go for knowledge these days.
Absolutely. And that's what I thought would be great about having Dr. Pierce on the show. He's a really educated not only an educated doctor that works in the medical field, but he's very well-rounded in terms of, in terms of how performance enhancers work and using it, in both powerlifting and a bodybuilding setting.
Yeah, no, I completely understand and agree with you 100%. Dr. Pierce, let's start off. This is a pretty simple question. I know, like I said, you have your own clinic. I know you're a big believer in hormone replacement, stuff like that. Why should men take testosterone? Explain to me, and when should they take testosterone?
It's a great question. It's individually based. The data is pretty clear that the average guy loses about 1% to 2% of their testosterone per year from age 30 on. Now, there are certain things that you can do to accelerate that loss or decelerate that. So in general, the way I look at it is not a numerical type thing. I don't like to ascribe any particular number to any individual, and kind of more on symptomology. So, if a guy is feeling, listen, I'm in the gym, I've been doing this my whole life, my strength's going down, I'm not making gains, I'm gaining more visceral fat, or to their eye body fat. It's taking me longer to recover. Mentally, I've always been captain of industry or whatever the case may be. I've been able to handle stress, but now I'm not handling stress well. I'm irritable, I'm anxious, I'm nervous, maybe even depressed. Any combination of those. Those are all indicators, that the testosterone level is probably not appropriate for that individual. Forget about the sexual stuff, but that's what drives a lot of people as well. When erection quality or frequency of spontaneous erections goes down, drop in libido, that kind of stuff, that it's a kind of cumulative effect. But those are the things that raise people's hands and say, I may have an issue, and at least get tested.
Mm-hmm. And in your experience now, when people come in and say that they have all these symptoms, what's the range of the testosterone usually on people that are feeling low T, as we hear on TV?
It really varies because I assume you're talking about is total testosterone.
Yeah.
And really, you start reading the papers on this, and total testosterone means crap, means nothing. Although all the guidelines are set up based off of total testosterone,
Mm-hmm.
it really shows a misunderstanding in the medical world, endocrinology, urology, general medicine, and they just focus on that. They go, oh, you fall within the normal range. I'm more of a free testosterone kind of person. So I'm trying to when I look at total, I look at free, and, I'm looking for lab core value of around 20 or better. That's generally where I see most guys feel the best. And I've seen, just the other day, I seen a guy who was at 0.3. And
Wow.
you're like, okay, now, and his total testosterone was low as well, but who cares? Get that free up and it'll make a world of difference.
In my experience, don't you think that when total testosterone is lower, that free testosterone usually goes up, because the body would say, we don't have enough total testosterone and we better free up more to be available to get the job done? And why wouldn't the body do that?
Oh, that's a great question, why the body wouldn't do it, and I don't have an answer for that. But I don't typically see it that way. I see them kind of as a correlate, 1-to-1, low total, low free. There's some pretty good evidence, study-wise, that just improving like DHEA levels can drive the free testosterone. And I've seen it, but it's really very variable on each individual. So sometimes you get a significant increase. Most times I get a mild to moderate increase, though. And at the end of the day, I just need to know for that individual, has it made a subjective impact? Do they feel it?
Right. Do you think that free testosterone, and this is my theory, but I wanted to see what your thing is. Do you think that free testosterone has a very genetic component, meaning that you could have a guy who just might not produce a lot of total testosterone, but just his body just frees up a lot of testosterone, and they're the guys that are the great athletes when they're in high school and middle school. They're the guys who just have more aggression. Those are the guys that you say they're just genetic freaks. Do you think that that's a genetic thing, free testosterone?
Well, I mean, we know how to calculate it, and so we know it has to. It's based off of sex hormone binding globulin and albumin and other proteins, but the other proteins are such a small percentage, you can almost discount them. Is there a genetic component to the amount of sex hormone binding globulin one makes? Probably. I've made an observation, and I've been doing this 17 years, and I found that it's just observational. But if I've got somebody who's under 6 foot tall and generally around under 5'10" and of Italian descent, their testosterone levels are generally pretty good, and even better when you give them. You can run the bottle underneath their nose. Their levels go up and they stay up, and to the point where I've got patients I've known before I was even a physician, so we were friends. Yeah. And you're like, I'm following everything, but I'm not doing any more than you're telling me, and the levels, 2,000, and you're like,
I'm laughing because that's me. That's totally me.
Right. That's how I am too, and I think that it is.
Yeah. Well, Dom, you're under 5'10". You fit the Dave,
at one point was 5'10.5". I no longer am 5'10.5", but I was 5'10.5" at one point in time.
Yeah, I think when they refer to genetics too, that that's also like highly contingent on how your body responds to different hormones, not just so much, like what someone's structure may be. Like I see people sometimes too that you would think, based upon what they were doing for years, when they go for blood work, I would think that some of their health markers would be in terrible ranges. And then to my surprise, a lot of them aren't as bad as I actually thought they were. And then you have some people that are doing things more of a moderate, mild way, and then they go and get their labs done and they're completely turned upside down.
Yeah. I'll give you an example. Like I probably took steroids for 10 or 12 years or something like that. I think while I was competing, I was on hormone replacement for about another 10 years after that. And then I got married and I decided to have kids. So I went off of everything. I did the whole HCG, HMG, protocols that I kind of designed. And I didn't take any exogenous anything for 7 years until just recently. And during that 7 years, my testosterone range was not bad. It was in the like 450, maybe even hit 500 a couple times. And I never had like a sex drive drop or anything like that. My free testosterone was always on the high side, no matter how low my total testosterone went. And I just always felt good. Now, when I decided I had to get an ankle fusion done, and I wanted to make sure I healed properly because I was worried about it. So I went back on some testosterone. I was taking 50 milligrams twice a week. And like you just said, Doc, my testosterone went to like 1,400 total. Like, and that was like 5 days after a shot. And they were like, my cardiologist who's friends with me, he was like, how much are you taking? I'm like, and I told him, I said, I swear I'm not taking any more. There's no reason for me to lie. And he's like, well, you obviously don't need that much. And it was just like, I was like a hyper responder to testosterone. And, it was just really bizarre. And even now I take about 80 milligrams a week, and I'm probably in I'm at about 1,000 like that.
Yeah,
and I know guys that are on 600 milligrams a week, and they can't get their levels over 1,200.
No, 100%. It's not, I wouldn't say a hyper responder. I would just say that you are slow in metabolizing the testosterone. So when you put it in, it stays there. And then I've got patients that are literally medically, I've got them at a cc twice a week. So 400 milligrams. And that goes way above and beyond. But I checked their labs 5 days later, they're level 700, 800. They excrete it, they're just dumping it, right? And
why would that be? What would make someone's body do that?
It goes down to genetics, and I don't even know if we have the markers to look at that. I know you just interviewed a friend of mine, Carmen, and with her DNA stuff, and so she's got all that DNA information, but I don't think any of it has to do with the metabolism of hormones, or at least to our knowledge. And I attend all kinds of conferences, and this is a subject that's never even broached. So I don't even know if it's being studied, to be honest with you.
Now, one of the interesting things and obviously I do know Carmen very well, and I sell her DNA testing kits, and I've tested myself, and I came back as a very high converter of DHT, which I kind of knew already because I take finasteride for like hair loss. I've been taking it for 25 years. And even when I was on no testosterone, zero, trying to get the wife pregnant, my DHT levels on finasteride, on nothing, were still in the high normal range, So obviously, and my DNA confirmed that I'm a super high DHT converter. So my question is, are people who are taking testosterone not getting the benefits out of it? Are they converting it to other stuff, DHT, estrogen, possibly?
Right. Well, so, the average conversion of estradiol is about 3 to 5% of the total testosterone, and dihydrotestosterone is about 7 to 10%, right? And so
in normal people, right?
Well, just on average, right?
Yeah.
So do you, now the delivery method of testosterone can change that, right? So if you use a transdermal testosterone, you're going to get greater conversion of DHT because 5-alpha reductase lives in the skin, prostate and liver, but as soon as you apply it to the skin, it gets converted.
I didn't know that. That's interesting that you mentioned that. Yeah.
So, and then there's good pharmacokinetics to show that sub-Q injections are just as good as intramuscular injections of testosterone. However, if you do it true sub-Q, you're probably going to get a greater conversion to DHT, and I've seen that, versus more intra-adipose. So if you kind of put it in the fat, it'll get utilized, but it's staying away from the 5-alpha reductase.
Yeah.
Then I've heard people say, well, but aromatase lives in the fat. I haven't seen great conversions of estradiol, and I'll be honest with you. So what? I want people to get higher levels of estradiol. There's more and more data, and I know that's a subject that we're gonna cover.
We're talking about that,
but more and more data to show all of the benefits of estradiol in blocking it, reducing it, nothing but problems. So, if you want to live less and be less healthy, take an AI or block your estrogen.
Now, I've done shows with Jay Campbell, and he's also a very big guy on like not using aromatase inhibitors. He thinks they're causing most of the health issues with a lot of bodybuilders. What is acceptable estrogen levels and what's not acceptable estrogen levels? Because there are people, and Dom, you've seen this because I know we've talked about this before, where we've seen blood work on athletes, and the estrogen is like 1,800, total estrogen. I'm like, I can't even believe how high it is. I've never seen like numbers like this. And then other people are, you know, are in the normal range.
Shouldn't it be about 5% of what your total testosterone is, right?
But it's never.
It's about 3 to 5, right? You give it, right? So first off, the lab reference ranges for estradiol. I don't check total estrogen because, you know, we're really looking at the conversion of testosterone to estrogen. It's estradiol, right?
Mostly, yeah.
So that's what aromatase does. So I don't care about total. I really care about estradiol, and that's really where the world of benefit comes. You know, we'll cover that in a second. But those lab ranges are based off of a quote unquote normal testosterone level. So I think they're under 40 or something along those lines. And well, if you look at the reference range for total testosterone, it used to be 250 to 1100. Now they're dropping it down. It's like I keep mine there, but I think they're down to 900 or 850. Why? Because in the US, we're getting lower and lower testosterone levels, and they're saying, well, that's normal. Really? Okay. So let's lower the reference ranges. I'm sure Harvard's lowered their entrance exam scores because people are getting a little dumber, right? I don't know. I don't want to throw them under the bus. They're already in enough trouble, right?
Yeah, exactly right.
So, but you know, it's so when you look at those reference ranges, you go, okay, so if we say 850 and now you take 4% of 850, well, what is that? That's 32 plus 2.5 is 34, right? 34 and a half. And they go, all right, so if you're over that, and then you got doctors with myopic, you know, vision with blinders on that look at that number. Well, I got to do something to get you in that range.
Right.
So, you know, that's a problem. That's when they go into, well, you need an AI for what? Well, I'm treating the number for what? Right. Well, because I don't want them to get gyno. Oh, great. Well, 99% of people don't get gyno on testosterone replacement. So you want to give them a drug that's going to prevent something that's 99% likely not to happen. And it has a plethora of side effects. Right. You go for that, doc. You're hurting your patient, and you took an oath, first, do no harm, and second, administer no poison. And I'm going to say it's a poison. Right. So
do you think the aromatase inhibitor is the poison, or is it the low estrogen that's the poison?
Well, it's the aromatase inhibitor because it's creating the low estrogen.
No, but what? But is it? Does the AI itself pose any health benefits or health problems, or is it the fact that the person's estrogen is too low?
Well, it by its mechanism,
on those headphones don't
lowers the estradiol, right?
Take them off.
Yeah,
it lowers the estradiol, so that's what creates the problems. But you know, you think about it. You think about all the
because some people say the AI itself is not good for you; that it can cause like damage to the blood vessel walls.
But that's because of low estrogen, right? So the lower estrogen reduces, and I've got. Oh, geez, I printed it up. There's increased inflammation due to glycosylation secondary to AI use that lowers estradiol, right? So if you think about, you know, the endothelium or the inside lining of the blood vessel, that's very protective against all kinds of stuff. Estradiol keeps that healthy, and it reduces glycosylation, and glycosylation.
Explain what glycosylation is to people who don't understand.
Yeah. So glycosylation is, you know, an increase in the sugar coating on, let's say, red blood cells. So we measure A1C, right? The hemoglobin A1C is an average of what the blood sugar runs over a 90-day period of time. The way I explain it to patients, if you look at a red blood cell, it's round and it has kind of a hole in the middle with a thin membrane over it, right? So you think like a Krispy Kreme donut, right? And the A1C is the measurement of the thickness of that Krispy Kreme, the sugar on the Krispy Kreme donut. All those donuts have sugar on them. All our red blood cells have some sugar on them. But the greater it is, the higher the A1C will be. Now, if you take that sugar, well, we know that sugar is inflammatory. So you take that donut and you push it through a tube, what's going to be left? You're going to have some sugar on the inside of that tube when you pull the donut out. Well, that's what happens in the blood vessels, and especially in the microcirculation, where, you know, a blood vessel may have to fold to get through there. A highly glycosylated red blood cell will leave a lot of sugar, and then that kind of closes the lumen down as that sugar accumulates, and now you lose blood flow, and that's how diabetics start to lose a toe, a foot, a leg. That kind
Are you saying that low estrogen can cause glycosylation at just the same way that high blood sugar causes it?
Yes, and there's studies to validate that. It increases glycosylation, which increases inflammation. So much so that at a recent conference I was at, I was listening to one of the docs who's down there by you in Florida. He's actually got men on testosterone therapy, and if their estradiol levels aren't around 100, he's given them 2 to 4 milligrams of oral estradiol.
Really?
And he validated it with looking at coronary artery calcium scores that were coming down, looking at their cholesterol profile, their HDLs were going up, LDL and triglycerides were dropping. It was pretty impressive. Because I haven't gone out on that limb yet.
Well, you know what they always said, it's the ratio of testosterone to estrogen that's important. So yes, if you're a man, right? If you're a man that's aging and your testosterone goes down and proportionally ratio-wise your estrogen is now higher, you might have problems. Like they say, prostate enlargement can be due to more so that higher estrogen lowered testosterone, right?
Yeah, that's been proven to be wrong. No.
It is?
Because when we look at intraprostatic production of both estradiol and dihydrotestosterone, it's independent of serum levels.
Okay.
So the prostate does it on its own.
Okay. So you're saying that estrogen So is it important to restore the ratio to a higher testosterone, to estrogen ratio, or is there an ideal ratio that you want of testosterone to estrogen? And from what you're telling me, these guys in Florida that are doing it are raising their estrogen to try to match the testosterone, right?
Right. Well, they're just now they're looking at more levels, and because they're finding that when you get that level around 100, that was providing the benefits to both cholesterol and inflammation, right? So decrease in inflammation. There's a test that I think Quest does. It's called a glycans test, and they were looking at that and watching that come down, and you're going, oh wow, pretty impressive.
So you would think that then taking testosterone replacement and allowing your body to aromatize what it wants would be protective, is what you're saying.
Absolutely.
As opposed to, as opposed to not taking any replacement, and because let's face it, will estrogen go up on its own even if your testosterone is low? No, not usually, right? If you have low testosterone, you have low estrogen too. So,
well, it will in obese people, right?
Yeah, right, because they have a lot of fat.
You'll see that in obese people, and then you go, well, then how come they have a higher rate of heart disease and cholesterol and stuff?
Right.
The problem is the visceral fat is pro-inflammatory, so they have an abundance of that. So it kind of, and think about it. The increase in estrogen is the body trying to save itself. It's protecting itself by increasing the estrogen in these people, but it's not sufficient enough to overcome that inflammation secondary to the excess adipose tissue.
Right. So, Dom, you and I, like I said, see a lot of bodybuilders, and we see some guys that have bad heart issues. They have blockages in the coronary arteries. They have high cholesterol, even though they eat perfect diets. I know you look at a lot of blood work like I do.
Yeah. The thing that I noticed that I feel like is the hardest to get back is their HDL, their good cholesterol. And I usually find people that nuke their estrogen usually tend to have horrible HDL. And in terms of LDL, fixing that, I feel like is a lot easier than bringing back your good cholesterol. I've tried pretty much everything, and yeah, you can see some improvement, but to really bring back your good cholesterol, it seems like pretty challenging. But again, it would fall down to more of the ratios, because if your LDL isn't that bad, then it's not the end of the world. Then if your HDL is
that's my question. Yeah, that's my question to Dr. Pierce here. And I always tell people, and I don't like to pass on bad information, but my cardiologist agreed with me that if your LDL is at adequate levels, below 100, whatever, that having an HDL that's slightly suppressed because you're on testosterone replacement isn't such a big deal. Is that true?
Well, that is going along with what I feel is the incorrect assumption that cholesterol is the cause of coronary artery disease. I don't believe that, because when you say that, then you are discounting the function of the endothelium. Mm-hmm. So if you're going to tell me that it's cholesterol that causes heart disease, then you have to be able to tell me at what level that cholesterol precipitates out of the serum to become a plaque.
Right.
And it doesn't. So what ends up where the issue is in the endothelium. And so, I make the analogy of the endothelium as like a Teflon coating on a brand new pan. And if you take care of that pan and you use eggs as the analogy to cholesterol, you can take all the eggs in Costco and put them in that pan and cook with it. They're never, ever going to stick as long as you keep that pan clean and you take care of it. If you put one scratch in there, it only takes one egg to stick. So if you have, high inflammation and the endothelium's damaged, I don't care what your cholesterol is, you're going to be developing coronary artery disease. And to validate that, you got to look at the studies with statins, right? We've been using statins for 30 or 40 years. Mm-hmm. You can't show me a study where statins have reduced death in somebody who's never had a heart attack. It doesn't do it. It's not preventative medicine. Yeah. And so they don't reduce the risk of heart attack unless you've already had a heart attack, which means that you've already got coronary artery disease. And so now that portends that you already have a poor endothelium.
Right.
So, so it's all about inflammation. And then so you go back to the estradiol and it keeps the inflammation down.
I think the funny part too about like statins is they will actually increase your chances too of getting type 2 diabetes. And like one of the things that are terrible for your endothelium cells that can penetrate it is having elevated blood glucose, elevated A1C. That's really one of the leading causes, I think, of most cardiovascular issues, inflammatory issues. And I mean, I don't know, Dr. Pierce, you would know this. Do high levels of LDL, can that penetrate the endothelium wall?
No. I mean, I got a study right here I can pull up, and they show that if you have a healthy endothelium, it almost doesn't matter if your total cholesterol is 400. It's not going to do anything, right? I have patients, and I've validated this in patients, where I check their cardio CRP, which I believe is a marker of endothelial health.
C-reactive protein, that's inflammation, right?
Sorry, thank you. Under normal circumstances. So if you're sick and you test it, it's going to be elevated. If you are injured, you were rolling jujitsu or something and you got some bruising, it's going to be elevated. But in a non-injured, non-sick state, that level, traditional medicine wants it under 3. I want it under 1. And that tells me the endothelium is healthy. And there's another biomarker that goes with it, and that's fibrinogen. And if that fibrinogen is in the lower third, and that range is like 200 to 300, and then there's, 301 to 400, 401 to 500. Those are the 3 tertiles of it. If you're in that lower third and you've got a C-reactive protein low, I don't even care what your cholesterol is. Mm-hmm. And I've sent people for coronary artery calcium scoring, and they come back with a calcium score of 0. And I've got, a patient in particular, because I talked to him years ago about this, and his cardiologist going, your cholesterol is 350. You got to take this statin. He's like, I feel like shit, doc, when I take it. You got to take it. You're going to have a heart attack. And I said, well, let's just do this for sake of argument, because I've been following him for years. Right. And this before I knew about the fibrinogen, but I had C-reactive proteins in this guy that were 0 point. Right.
Wow.
Right. He went and got a calcium score, and his score was 0. I said, please go to the cardiologist and ask him how you're going to have a heart attack if you don't have an effing plaque that can rupture.
The statins supposedly increase inflammation too. They're pro-inflammatory. From what
I've heard both sides of that. But to Dom's point, right? 1 in 50 people that take a statin will develop type 2 diabetes. Now, what are we trying to do? Oh, we're trying to reduce the risk of a heart attack. So you have to treat, in somebody who doesn't have heart disease, you have to treat 104 people for 5 years with a statin to reduce the risk of 1 non-fatal heart attack. So if you look at those numbers, you got to treat 100 people to reduce for 1 heart attack, but 1 in 50 are going to get type 2 diabetes. And to Dom's point, do diabetics have a higher risk for heart disease or a lower risk? We all know
Way
that
higher.
take it a step further. They have a higher risk for all types of cancers. So you're increasing the risk for cancer. You're increasing the risk for heart disease, twice that of what you're doing to protect them from having a non-fatal heart attack. So, and I'm not saying don't take a statin. If your doctor tells you to take a statin, take the statin, right?
Right.
But I think there's a better way to do it. And that is, kind of, if you want to lower the cholesterol, okay, lower it. But generally that's through diet, exercise, good supplementation, things of that nature. These are all positive anyway. And then we can do some other things hormonally that can help to reduce inflammation, and reduce that risk of heart attack and stroke.
I think, and you brought up an interesting question about type 2 diabetes and running high blood sugars, because I've recently really delved into that, because I'm petrified of, as I get older, becoming demented. That's like my fear for some reason, because I saw it happen to my dad. It didn't happen until he was much older, but no one wants to lose their memory, and I think that, and they're calling even dementia now type 3 diabetes, really, whereas, that sugar, and it doesn't have to be very high. It could just be a little higher than it should be over years and years and years, accumulates in the circulation in the brain. And like you said, it just closes off that circulation. Eventually there's no blood supply to the brain cells. And so, I noticed that as I got older, I'm 55 now, I noticed that my fasting blood sugars were creeping up higher and higher in the high 90s, sometimes even over 100 when I wake up. And I eat a pretty clean diet. I'm not an excessive carb eater by any means.
You got a lot of great muscle mass too.
Yeah, and I have zero body fat. So I said, you know what? It's unacceptable. I don't think a 5.6 hemoglobin A1C is acceptable to me. And so I started taking a long-acting insulin. I take 2J, which is like Toshiba, and I've gotten my hemoglobin A1C around 5.
Okay.
And I wake up in the 80s, most mornings, my fasting blood sugars. I feel great. I look good. I haven't gained any body fat from it. And I think it's I think it's going to be the next testosterone. Like, we take testosterone for replacement to feel better. I think a lot of more people should be taking a long-acting insulin as they get older to keep those sugars down. What do you think about that, Doc? Dom, you want to talk first to it?
I mean, I know what you're thinking, probably, like, because from a bodybuilding perspective, it makes sense. And I use that a lot of times to help fix prediabetes instead of putting someone just on like metformin, especially if they're a bodybuilder. I'll actually use Lantus to kind of rest the pancreas and give their pancreas a little bit of a break and slowly taper them off of it. But I would think in your case, I'm surprised you didn't go with something like metformin, because I mean, you're not concerned about like things like putting on a ton of muscle, like if you're blunting mTOR or IGF.
I'm going to tell you why. Here's my thinking, and I thought very long and hard about this. Bodybuilders work out right, they eat right, they don't have a lot of body fat. We know exercise, omega-3 fats, fish oils, all increase insulin sensitivity. So I don't buy into that bodybuilders are insulin resistant at all. So if bodybuilders in my mind are running high blood sugars, it's because they're just not producing enough insulin. Now, why is that the case? Maybe from years of growth hormone use, maybe it's just genetically in their body, in their body types. Genetically, when they hit a certain age, they don't produce as much. The beta cells can't crank out as much insulin. We also eat a lot more food than the average person. Even if though I'm not eating like I was years ago, 12 meals a day, I'm eating 5 times, 6 times a day. That's still my insulin requirements are higher than the average person. And I just think that your body just can't produce. I don't produce enough. I never did. Even when I was bodybuilding, I had to take insulin when I was, eating 12 times a day to absorb my food. So in my situation, and I think in most people who work out, taking, insulin sensitizers or drugs like metformin that prevent the liver from releasing glucose, I don't think it's solving the problem, which is an insulin production problem.
It's putting a Band-Aid on it,
right?
Really.
Right, and that's why I take an insulin supplement. You want to say something, Dr. Pierce, about that? What's your thoughts on that?
Well, so you're talking two different worlds, right? You're talking normal physiology, and then you're taking to the extreme in bodybuilding. And so I think you nailed it when you talked about, the amount of calories, 5,000 to 6,000 calories. The average person doesn't eat that much.
Right.
And if they did, they'd have a whole lot of problems, right?
Right.
So, that changes the physiologic requirements. And so, the pancreas is designed to kind of control for a normal intake of about, 2,000 calories or so, right? So to your point, your pancreas probably isn't capable of producing the amount of insulin needed to intake that amount of calories. And so, an additional source may be needed in that extreme. But the average person shouldn't have that problem. And if they do, then you got to kind of look at what's going on in the pancreas. And then kind of a lot of that stuff has to do with visceral fat, because as that fat accumulates, that decreases beta cell production and even, in function. So, now, again, bodybuilders don't have a lot of visceral fat. True, in most cases. But we're talking a different physiology. So, now if you're not eating, 5,000 calories now, and, you're only eating 2,000, I don't know that it's a pancreatic issue, but did you check your fasting insulin levels? Yeah. And have you done a glucose tolerance test with insulin levels to see?
No, but I don't produce a lot. When I've checked insulin levels, I don't produce a lot of insulin. Okay. I'm not a big insulin producer. Probably, which is why I always stay very lean too, because I'm not an over insulin producer. But I think, I don't think my blood sugar was ever a problem. And I eat more probably than the average person eats now because I have very fast metabolism, but I don't eat anything close to what I did when I was bodybuilding,
Right.
But I see it in a lot of people, because I have all my clients, and I know Dom does this too. We have all our clients test fasting blood sugars, and a lot of bodybuilders, whether they're on GH or not, whether they're on, a lot of them who are not even taking any drugs, just the guys that are eating 6 times a day have high fasting blood sugars, over 100. And I was shocked at the data I'm pulling in, and I'm like, you know what? There's no way it's an insulin sensitivity problem. These guys are lean, they're ripped, they work out, they do cardio. It's got to be that their pancreas just cannot produce enough insulin.
But Dave, the thing to do, wouldn't you think this, is to also have them check their blood sugar about 2 hours, 2.5 hours.
Oh, I do that. They're always normal.
Carb and protein meal.
Most of them are normal when they do that. It's just the fastings, but that's called first phase. That's when your pancreas is telling your body, I can't keep up. Once you get to there are people that are running high 2-hour, postprandial sugars. Once you get to that point, you're pretty, your pancreas is pretty much, messed up at that point.
Because if it's that point, then then your pancreas is it's just not producing enough insulin. Right. Then for sure.
But you don't want to wait till it gets to the point where it can't even keep up at a meal. You know what I mean? Much less fasting. So.
Well, there's another piece to that, I think, if I may interject.
Yeah, yeah, sure.
You want to, first, there's 2 things to think about. Number one, are you sure that they fasted for 10 to 12 hours? Because if they're eating that frequently, it might be difficult for them to actually do that. And they go, oh, well, I'm taking a little something, and that little something may be enough. Number one. Number 2, if they are, remember, their body is used to having calories in every couple hours. Now, all of a sudden, you remove it. What do you think that's doing to the sympathetic nervous system? That's gonna put them potentially in a hypoglycemic state, which is going to upregulate cortisol and epinephrine, norepinephrine. So by the time that you test, now they're getting gluconeogenesis from the liver because they're used to having those higher levels. So it's that's why.
Right, but why isn't their pancreas, accommodating that? All right, you know what? Great. The liver just cranked out a ton of glucose because I'm about to wake up, the dawn phenomenon, and the fact that my blood sugars might be a little low because my body's looking for food. Why isn't the pancreas crank out enough insulin to lower it? It's not like they just ate a Danish or a muffin, or a donut, but yet the pancreas can't keep up for some reason,
Yeah. And that I think is more to, don't quote me on this, but I think there is an effect when you increase the catecholamines, the stress hormones, to where insulin kind of comes down, and it makes sense, right? Because you're not trying to digest food in a fight or flight response. You're trying to run, right? You're not, so the body wants that fuel available, right? But then you need that insulin to be able to co-transport it into the muscle cell. So I just think the real answer, if you think that somebody's not producing enough insulin,
right, is
a glucose challenge with that test with insulin levels, so you can actually see.
Right. And some people, you're right. You know what? Because if I think the confirmation test really is hemoglobin A1C, right? So if you get someone who's waking up at 100, blood sugar in the morning, but the hemoglobin A1C is 5.2, they probably don't have a blood sugar control issue, But if they're waking up at 105 in the morning, and this is more the case, and then their hemoglobin A1C is 6.5, and their doctor says, "Oh, you're fine. That's still normal." That I have a problem with that. I would not want to be walking around with a hemoglobin A1C of 6.5.
No. And so what I've noticed in a lot of folks that are eating, every couple hours, is that their A1Cs do come up back a little bit more elevated than I would expect. And it makes sense to me because they are never really dropping their blood sugar, right? So they're eating, they're training, they're doing whatever. And by the time their sugar would drop, they're refilling the tank.
Right.
And so and remember, that's an estimate of the average daily blood sugar. So if you're not letting it get too high, but you're not going to the lows, and you just kind of stay in mid-range, well, that's going to probably be that A1C of 5.5 to 5.8 in that range, right?
Yeah, maybe. I mean, I guess.
It's an observation that I've made.
Potentially, you're correct. Let me ask you this question. A lot of people who take hormone replacement notice that their red blood cells go up tremendously. I can't tell you how many questions I get per day. How do I prevent that? I said, you can't prevent it. It just happens. I know people on like 50 milligrams of testosterone a week, and they get high red blood cells. I'll tell you what I tell people, and you tell me if I'm wrong.
Go for it. I'm going to take a drink of water while you tell me.
I feel that if you start dumping blood, which is a lot of these doctors,
you produce more red blood cells.
Yes, you produce more. It's like your body's saying you're bleeding. Produce more red blood cells. I see the levels go up and up and up. I said you're better off not giving. I mean, runners and the cyclists try to get more red blood cells into their body to get better oxygen carrying capacity. I always felt as long as your platelet levels are normal, I don't think there's anything to really be concerned about. What's your thought on that? What's too high? What's a point where you shouldn't touch it? Should you even dump blood?
Beautiful can of worms, but it's beautiful, right? Because I've actually got studies they're all right here that I've pulled up from. I just went to this great lecture in San Antonio, and just more and more data keeps coming out about this. So I'm going to just kind of summarize it, but there's no reason to dump blood. Zero.
Thank you.
Because here's where the problem is. People, and when I say people, physicians, and for the most part, mislabel what that's called. So it's called secondary erythrocytosis. The erythrocyte is the red blood cell. Right. I mean, just an increase in red blood cells. Okay. Right. That's it. It's no different than living at altitude. I think the data is about 200 million people live above, I think it's 2,500 meters. So whatever that is in feet in the world, right? I always make the little analogy of this. I say, if you move to Vail and your hemoglobin hematocrit is elevated, and you got people walking around Vail with, hemoglobin of 20 and a hematocrit of 60, and they're not on TRT, just kind of walking around like that. Are they going to their primary care doc, and is their primary care doc phlebotomizing them? And if so, for what reason? And if they're saying, well, it increases risk of heart attack and stroke. Okay, now where's the warning sign outside of Vail saying, warning, living here is going to increase your risk for heart attack and stroke? Because if it did, I can guarantee you all of these ambulance chasing attorneys would all have an office in Vail, because they're going to try to sue the state of Colorado, right? They want their chunk. But it doesn't happen, right?
Yeah.
So increase in hemoglobin hematocrit has no health impacts, period, if that's the only thing, right? When it comes to testosterone replacement. So, but here's where they get it twisted is they confuse it with the data from polycythemia vera, which is a blood disease. And polycythemia vera does increase platelet count and some neutrophil aspects as well. So it's polycythemia, multiple branches of blood cells, not just erythrocytes, right?
Yep.
So when they look at that and you go, oh, those folks actually have a higher risk of blood clots. Yeah, well, or blood clots, yeah, because it increased their platelets. But TRT does not do that. And every single study that's looked at it has shown that. And they go, well, okay, so they come up with hyperviscosity. Well, it's so thick that it's going to. No randomized control study has shown that. No retrospective study has shown that. So you're speculating it, but it's not true. And we don't see it in elevation. So then, so why are you dumping it? Well, I actually have patients say, I feel a little bit better. Well, if that's the case, I tell them, go for it. You've got plenty of red blood cells, but there's no medical indication for you to do this. Right. And I just leave it at that.
I mean, unless you had like high iron levels, I mean, there'd be no reason to really dump blood.
But the iron gets converted to red blood cells. Now, what you're talking about is hemochromatosis, which is a disease, right? And so that's a different thing.
Or people who are dumb enough to take iron supplements when they don't need it as men, and they build up, levels that are too high in their bloodstream.
Well, you bring it right. So the question is, why does testosterone replacement cause this? And then generally we see it within 48 months. If you've been on for 2 years, if you're going to do it, you're going to do it in that window, right? But why does it do it? Well, there's some speculation that people say, well, it's EPO, and then they've tested that and they go, no, it's not EPO, and they so it's not the same mechanism for high altitude. But really where it is estradiol plays a role in this. But more so, there's an enzyme in your liver called hepcidin, and hepcidin regulates your iron uptake. So if you're on testosterone and your twin brother's not on testosterone, he's going to have a higher hepcidin and you'll have a lower hepcidin. And if you eat a steak, you are going to absorb more iron from that steak than your twin brother. And what does your body do with that iron? It turns it into red blood cells, right? So that's one of the main components of the increase in hemoglobin hematocrit.
Interesting.
Now, here we live in the desert, and so I see people, their hemoglobin hematocrits are high, and then I look back at their renal functions and their albumin levels and go, oh, you're dehydrated. So we do see some hemo concentration.
Gotcha.
So I tell them, make sure you're drinking at least a gallon of water a day, and then come back and test, and lo and behold, it's normal. But bottom line is that we just got the results from the Traverse trial that looked at testosterone and kind of its effects for coronary artery disease, for heart attack, stroke, and it also looked at the erythrocytosis, and they showed no increased risk for MACE. MACE is major adverse coronary artery or coronary vascular events, right? We didn't see any of that. So, again, no reason. And there's, where did I put it? I got one study that I thought was pretty interesting, but it basically looked at guys on TRT and found that they had, once their hematocrit was above 49, they actually had a lower risk for coronary artery disease than the people that had their levels above 49. I'm trying to find.
You know what? I think we live in a society today where they always try to vilify testosterone. I don't know why. It's okay for a 12-year-old girl to be on the pill on estrogen, but God forbid, a guy in his 30s or 40s wants to take some testosterone to feel better or more youthful. They have to they love to vilify it. And I mean, I'm sure as a doctor who prescribes testosterone, you're always fighting the establishment on this. You have to be.
Well, unfortunately, I don't have to fight them because I don't take insurance. I don't play their games. They're not in business for your health.
Smart.
They're in business to make money. And so, you're just a commodity as a physician and as a patient. but you're absolutely right. And you know, there's probably everybody's got a conspiracy theory to it, but I'm not even going to go out on a limb. It just seems like, listen, we all know if a guy's got lower testosterone, he's probably a little less assertive and probably a little easier to control.
Yeah, exactly.
We'll just put it that way.
Yep.
I think another thing too that has to do with it is that a lot of times when it's prescribed, it's misprescribed. And what I mean by that is, I mean, we have a lot of people that come into Ageless from other clinics. And when I'm talking to them, you know, these are guys that are younger in their early 30s. They have been on hormone replacement therapy for a while, and, you know, they'll come in, they'll be like, yeah, you know, I've been trying to have a child over the last couple of years. And when they go into these places, some of these other places, they don't talk to them too much about that. They are just so quick to get them put on testosterone and, you know, not really understand that everyone's situation is totally different. And, you know, someone that is trying to conceive a child within the next couple of years, they need to communicate that with their doctor. I think it's cases like that, also cases of people going into some of these clinics and they're over prescribing them all these anti-estrogens, which that's leading to all these other different sorts of health issues. And then they're going ahead and they're blaming the testosterone for it. And that kind of feeds into all this mess.
Yeah, no, 100%. What, Doc, just to kind of wrap up this great conversation we're having here, nutritionally supplement wise, I mean, what do you think are some of the most important supplements that people subsidize their diet with? Because we know that, you know, vitamins, minerals, trace metals, essential fats, they all, you know, aid in all the essential, you know, chemical reactions in our body. And in terms of, you know, the most bang for your buck, so to speak.
I have, you know, I work on the KISS principle, and not the military one, because I can't figure out who's stupid in that, so it must be me. Right. So as somebody said, yeah, keep it super simple. So I use that one. I like it. So
yeah.
But you know, in no particular order, I think it's omega-3 fatty acids, a good multivitamin, vitamin D in sufficient quantities, and probiotics.
Yeah.
I think if we all did that, we'd probably be a whole heck of a lot healthier. I remember my third year of med school, somebody, I think it was someplace in the UK, they made a proposition that they were going to put aspirin, statin, calcium channel blocker in a pill and distribute to everybody. And I went, what are you talking about? And, you know, and I'm a med student and they're telling me this, and I'm just shaking my head going, you guys are idiots. But I have to bite my tongue because I'm just, you know,
what year did you go to med school again?
I went in 99. So
okay, so you were a little after me. When I went in 90, and I tell people this, and I swear on everything that I hold holy, that we had one day in medical school of nutrition. One day. It was like some guy reading from a book about how vitamin C prevents scurvy, you know.
We had it. We had same. We had one day, and it was this big fat surgeon that was talking about, you know, that you know, the food pyramid and this and that, and I'm like, you know, and then he started talking about parenteral nutrition, and so back then, and it just started to switch maybe a year or so after, but back then they were giving like I think it was like maybe 10% fat, 10% protein, and 80% carbs in the parenteral
all sugar,
nutrition. And I'm like, this makes no sense. Zero. These people are, well, they need the glucose to heal. No, they don't need that much.
Right.
They need more fat and more protein.
Right.
And so, and then he's saying this, and I'm like, oh, it's okay.
I
can't sit back here and listen. So I rose my hand and I said, you know, that just doesn't make sense. And he's like, well, and then he tried to like talk down to me. And I said, sir, respectfully, look at you, look at me. Who do you think knows a little bit more about nutrition?
He didn't like you after that.
He didn't like me at all.
You know,
they wrote the food pyramid, I believe, to help feed into diabetes personally, because the way that
it's for the farmers, it's to sell more wheat and corn. That's why.
Right.
And to feed into diabetes 100%. I would probably add a soluble fiber supplement to, like, if someone asked me if you could pick one, that's probably the one I think that I would pick.
just soluble fiber by itself over everything else?
Doc, my number one selling product is Fiberlize that I make. It's by far, I sell the most of it. I have repeat customers for 10 years on this product, and people need a good quality fiber supplement that tastes good. And, we produce this, I did a lot of research into fiber before I came up with it. Psyllium is by far the most
Psyllium
potent.
husk,
It's the most potent soluble fiber, but there's different grades of it, where they call them swell rates. So the highest swell rates, which is cost the most expensive, no one uses. And when I didn't even know this, but when I got into this whole business of trying to create a fiber supplement, because I knew how important it was for detoxification, feeding the gut bacteria, all that stuff.
Even for blood glucose, it's amazing.
Blood glucose control, right. So we use the highest swell rate in Fiberlize. That's why when people use our product, they say, Dave, I don't understand why it works so much better than Metamucil, which is, another psyllium-based product. I said, because Metamucil mixes really easy because it's a low swell rate, and you get some health benefits, but not as much. But yeah, I think a lot of people don't realize that the detoxification aspect of supplementation is just as important as giving your body the right nutrients that it needs to absorb.
So is that psyllium then? Is that considered like a prebiotic?
Yes.
Yeah, it would be. Yeah, it absolutely would be.
And like the probiotics that we're taking, they're kind of essentially useless without a prebiotic.
You're right.
So it works hand in hand. And someone randomly had asked me that question the other day, which it was a hard question to answer. If you had to pick one supplement, and I thought about it, and that would definitely be the one that's probably up there. The other ones that you named too are obviously important as well.
Well, I could have done the Andrew Huberman and named a product that he promotes. So.
Of course. Yeah.
Doc, I'm gonna send you some Fiberlize. I want you to try it because it really is. It's a unique product, and a lot of people don't realize how much they need a fiber supplement until they actually use a good fiber supplement. And then they're like, oh my God, I can't believe how flat my stomach feels, how good I feel, how much energy I have. And because people don't understand that as they get older, the colon is a muscle, it deteriorates because we don't eat enough fiber in our diet. And it doesn't do its job of moving waste through the
that's why we got such profound numbers of diverticulitis, right?
100%. 100%.
So my question to you with this fiber product is timing. When, can you take it with other food supplements? Is it going to absorb certain things?
I don't take it with fats because I think it binds fats, but I usually take it like in the middle of the day, sometime like between meals, and then I take it always right before bed. So when I wake up in the morning, I know I'm going to the bathroom in the morning because it's not a laxative, but it puts you on a schedule. It'll put you on a schedule.
I just because my pre-workout has got phosphatidylcholine, and it's kind of got a fat, and I wouldn't want.
Yeah, I wouldn't mix them together. I do them in between meals. Yeah.
Okay.
I think at night before you go to sleep is the best because then when you wake up in the morning, once someone is consistently using a product like that, you'll go to the bathroom every day, on the minute on the clock.
Well, I do that anyway, but that's okay.
But it's a more complete go to the bathroom.
No,
that's the best way I can explain it without getting too disgusting about it.
Right. We don't want to make this a crappy podcast, right?
No pun intended. So, hey, I want to thank you for joining us, both of you. Both, Dom, you're always welcome on the show. We'd love to talk with you. And Dr. Pierce, some great information you gave us here today. And if people want to get in touch with you, what's the best way?
We can reach out to us through our website, www.agelessforever.net. And then the number here in Vegas is 702-838-1994.
Okay. I'll put it in the description below too, guys, if you
when you call, ask for Dom because
I meet with all the new patients.
I got you.
So yeah.
Are you doing this full time now, Dom?
What was that?
Are you doing this full time now?
Not full time, just 2 days a week because I still have my full time coaching business. But no, I mean I love it, and his clinic is totally proprietary to any other one that I worked at because he doesn't do just hormone replacement therapy. He does recovery type programs. I mean a lot of preventative medicine. So his clinic is entirely different than anyone I've ever seen.
Cool. Thanks for joining us, both of you guys, and appreciate the knowledge. If you have any more topics, Dominic, I'd love to have you both back on again.
Thanks.
Absolutely.
Thanks, Dave. Thanks, Dom. You guys have a great day.
And that's going to take us to the end, guys, to another episode of Guru Talk. I'm Dave Palumbo with Dom Mutascio and Dr. Pierce. We'll see you next time.